So I will be doing a quick take on the recent meta-analysis published in the Lancet on statins in older adults. I have no conflicts of interest. As probably everybody on this call knows, statins have been conclusively shown to improve cardiovascular outcomes in sort of typical adults. The evidence base is less established in our patient population, so older adults. And there's been some heterogeneity in the findings of previous trials. Two large RCTs, Prosper and HOPE-3, both showed no benefit for primary prevention of cardiovascular disease in low and intermediate risk older adults. And so there is an interest to try to clarify this based on a review of previous trials. We also know from observational studies that statin therapy tends to be underutilized, even if appropriate, in older adults. And so there was a question as to whether we could estimate what benefit we might be missing out on. But generally, there remains some uncertainty about the relative risks and benefits. This is drawn directly from the current CCS guidelines on dyslipidemia. And it basically says that there should be an individualized approach for those over age 75 because of the lack of extensive study in this area. And similarly, hot off the presses, the American guidelines have a relatively nuanced approach where they both say that adults aged 75 and older may benefit from a moderate intensity statin, but conversely, you might also be reasonable to stop statin therapy if there are things such as functional decline, frailty, or reduced life expectancy. So again, a somewhat nuanced approach. So moving on to the trial itself, published in the Lancet in February of this year. They enrolled patients from, or rather they included patients from 28 trials as part of the cholesterol collaboration trialists group. They had around 187,000 people. 4 trials with patients with heart failure or dialysis were excluded from some results, and they were unable to get individual data from 4 additional trials in their registry. I'll note relevant for us is that only 8% of the trial population was over 75. So it's although it's a large number, it's a subgroup of people. The intervention was statin therapy or a more intensive statin compared against no statin or less intensive statin, and outcomes were major vascular events, mortality, and then anticipated side effects such as cancer incident, and expressed as a rate ratio versus 1 millimole per liter reduction in an LDL. So they included randomized trials only. The purpose of the trial had to be to reduce LDL cholesterol, and it had to be only based on statin administration. It couldn't be based on things like diet or exercise intervention. And the trials had to be large, at least 1,000 participants to be included. And like I said, while they report some data, including these trials, a lot of their results exclude 4 trials that exclusively had patients with severe heart failure or who are receiving dialysis because of demonstrated lack of evidence of efficacy of statin therapy in those patients. They originally pre-specified 6 age groups, but they later split it into a binary of greater than or less than 75 for lower event rate outcomes. And everything was analyzed on intention to treat. So this is the breakdown of the groups comparing the less than 75 to greater than 75. You can see that less than 75 is kind of way outside of our cohort average age of 62. And even the greater than 75, their average age is 79. So kind of relatively on the younger end of the spectrum of what we might see. And there's heterogeneity between the groups for the ratio of sex, comorbidity status, smoking status, cholesterol, which was adjusted for. So moving on to the results. The key result that they report is that statin or more intensive statin, basically giving people additional statin therapy, has a favorable effect on cardiovascular event risk. So there was a 21% proportional reduction in the risk of a major vascular event per 1 millimole per liter reduction in LDL cholesterol. And you can see in the forest plot on the right, the panel A at the top shows the results broken down by year. It looks like things are trailing off slightly for the cohort at the bottom, greater than 75 years, but actually they still report an 18% reduction specifically in that group that has remained significant. and there was no trend for decreased benefit with age. And the B panel shows when they removed the heart failure and dialysis trials I had mentioned, and that's because they disproportionately included older adults, and so had skewed the results. So overall, a proportional reduction in the risk of vascular events for those older adults who receive statins. They saw a similar pattern of benefit when they broke things out by specific vascular events, so myocardial infarction, need for coronary revascularization, stroke, etc. In some of these analyses, they found that there was a reduction in the proportional benefit with increasing age. So as people got older, while there was still a benefit, it tended to wane. But the absolute benefit still remained, keeping in mind that older adults are also more likely to have cardiovascular risk factors and pre-existing cardiovascular disease. So there is still some benefit. And they, of note, they did report that the proportional risk in stroke did not differ significantly with age. So specifically in patients with stroke, statins are always of benefit. They also broke things out in patients with or without pre-existing vascular disease. And in that case, they define it as cardiac vascular disease. So MI, known coronary disease, or left ventricular dysfunction. And in patients who had vascular disease, they confirmed their previous results that all age groups benefited from statin use. So secondary prevention, statins are useful regardless of age. But in patients with no pre-existing history of vascular disease, they found that adults, and you can see in the top panel that the greater than 70 and greater than 75 cohorts both cross 1 on the forest plot, and they found that there was a significant reduction in proportional benefit in those older adults. So primary prevention was not necessarily beneficial. And so they concluded that in adults over age 70 without a history of vascular disease, that there is no reduction in risk of major vascular events. The caveat with this is that this is a subgroup of a subgroup, in that this is already like around 12% of the people they included, and then only 20% of those people, so 1/5 of those people, had no vascular disease pre-existing. So it's a kind of an elite group that they're extrapolating this information from. And they do report that there was no effect of statins on other outcomes, including cancer incidence or death, which has been kind of, if those who follow the literature, has been brought up on multiple occasions previously.
As a red herring.
As a red herring, indeed. So in terms of the critical appraisal, using a common tool for looking at meta-analysis available at the reference below, quickly going through this, the research question is certainly clearly stated. It's a clear extension of previous research. It's actually a little bit difficult to tell whether relevant studies might have been missed. So they enrolled all the trials that they could from this collaboration, but the references they used for their search strategy is actually from 1995. So it's hard to be totally certain that they haven't missed something. And they do say that they were unable to get individual level data for 4 trials that they did identify. Inclusion criteria were appropriate, and they did present data, for example, of the heart failure and dialysis patients, both with and without those patients. So I think it was reasonable. The included studies were certainly valid for the study question. The caveat being, again, that they're trying to look at the results in older adults, and that was only 8% of their participants, really. And even looking at those 8% of older adults in typical cardiovascular trials, those would be healthier than those that we would see in a geriatrics clinic. And so whether this is totally generalizable to what we might see practically is a little bit unclear. And certainly there were consistent effects study to study. Statin benefit was generally favored, as we saw in the forest plots. And they do report heterogeneity when present and assess with statistical testing and adjustment. So the bottom line, I would say, is that statins reduce the risk of major vascular events in older adults. This effect is most pronounced in those with pre-existing vascular disease. And for some specific outcomes that may wane, but keep in mind that the counterpoint to this is that there's a higher absolute burden of cardiovascular disease as age increases. And so when they actually calculate the absolute benefit out, it's actually relatively stable across age cohorts. Statins may not be beneficial for primary prevention for adults over age 70 without a history of pre-existing vascular disease. And there is a prospective RCT that's currently taking place examining this specific question. So we'll have more information in 2 or 3 years. And so I'll open the floor to questions.
Good morning, everyone. Thank you for coming. I wanted to try something similar in a way, but also different from what we would usually do. I wanted to apply a lightning rounds approach to the critical appraisal of randomized control trials of cannabis use in older adults. So myself, and I'm sure many of you, are starting to see a lot of patients using cannabis, but also to get a lot of questions from patients and their care partners about the evidence for its benefit and safety. And so I've been doing a lot of reading around this. And of course, we've probably all been to a talk about sort of cannabis use in general, but I thought since this is Journal Club and the focus of Journal Club is to be on critical appraisal of the literature, that we could try and critically appraise the very few RCTs that we have in our patient population about cannabis use. So what I did is I looked at, there was a CADIT review that had been completed recently for RCTs, and then there'd been a couple of other systematic reviews that I looked at to try and find the RCTs that we could talk about today. And
Jennifer, can I ask, hold on for 1 second. Sinai and Baycrest, would you mind checking to make sure you're muted now? And Jen, if you could put the mic a little bit closer to you, it might help. Oh, that would be good. Maybe get rid of the cardboard. Okay.
Is that better?
Yes, thank you.
Okay. So given the nature of the presentation in particular, I would just want to make it clear that I have no actual or potential conflicts of interest in relation to this presentation. And this will be the format. So for each study that we discuss, there'll be a slide that talks about the publication details. Then there'll be a slide on the PICOST, so population, intervention, comparator, outcomes, study design, and timeframe. Then there will be actually 1 to 2 slides on the results. So usually it will be 1 slide for efficacy, 1 for safety. There's 1 study where we only have 1 slide though, just because there weren't a lot of results. Then we'll spend 1 slide to do critical appraisal and the last slide to sort of put it all together. So very similar to the short presentation that we do in a way. Just to clarify, because we'll be doing a lot of critical appraisal today, the tool that I'll be using. So I will be referring to the Cochrane risk of bias tool. So for those of you who are less familiar with this tool, there are 7 different domains that it assesses, and you decide if something is low, unclear, or high risk of bias. So for randomization, the question is, how were participants allocated to their intervention groups? For allocation concealment, how was group allocation concealed from participants and assessors? For blinding of participants, so was it adequate or not? Blinding of assessors, same thing. For missing data, what we mean is, how many people did they lose to follow-up? How much data was missing? And if there was quite a bit of data missing, how did the authors account for that in their analyses? For selective reporting, what I really mean is, was the study registered? Did they publish a protocol ahead of time? And everything that they put in the methods that they say they were going to report, did they actually report it in the results? And then for other bias, that could be different things, but given the nature of the studies we're going to look at today, I thought I would refer to whether or not there was any kind of pharmaceutical company sponsorship, and if so, how did the authors mitigate any potential conflicts of interest? So the first study that we'll talk about was published in the International Journal of Geriatric Psychiatry in 1997. And it was on the effects of dronabinol on anorexia and disturbed behavior in patients with Alzheimer's disease. There is a paragraph there that is probably appearing small for many of you, but the reason I put that there is that that's the author's statement around sponsorship for the study. And they say the study was supported by the Department of Veterans Affairs, Roxanne Laboratories, and the Unimed Pharmaceuticals. And they give details in the study that it was Roxanne Laboratories that supplied the study medication, but they don't say otherwise how these companies were involved in the development, like in the planning, conduct, and reporting of the study. So this is the PICOST. So this was a 12-week crossover randomized control trial. It included 15 hospitalized patients with probable Alzheimer's disease who were refusing food. Their ages ranged between 65 and 82. The mean MMSE for people was 4, so they were quite demented. And what's important for this study, given that we're looking at anorexia, is that they're actually fairly small people. So the mean BMI was 22.6, and the range was from 16.9 to 26.2. The intervention group received dronabinol, 2.5 milligrams PO every morning and at noon, and the comparator group received a matching placebo. They looked at a number of different outcomes, including the Cohen-Mansfield Agitation Inventory, which looks at aggressive and agitated behaviors, the Lawton Observed Affect Scale, which looks at symptoms of positive and negative affect, body weight, tricep skin fold thickness, caloric intake, as well as adverse events. And while they don't say specifically when the study was done, the study was published in 1997, so we know it had to be at least before then. In terms of treatment efficacy, some of the reporting made it very difficult to really know what was happening. And so that's one of the main shortcomings of this study, actually. So what the authors tell us is that in terms of body weight, the group that received, or when the patients were receiving dronabinol, remember this was a crossover study, so everyone got dronabinol. It was just a question if they got it before or after the crossover. They gained 7 pounds and then 2.3 pounds. And then the placebo group gained 4.6 pounds and then 1.7 pounds. But so everybody gained weight, in both groups. But what's not clear is if people actually gained more weight on dronabinol versus placebo. The authors don't explicitly say that. There was no, the tricep skin fold thickness was unchanged, caloric intake was unchanged, the Cohen-Mansfield Agitation Inventory score was unchanged, the positive affect score was also unchanged. And then this is the quote from the study authors to do with negative affect. So they say negative affect decreased during the 12-week study period, and it decreased more while patients were on dronabinol than during the placebo periods. So they might mean that dronabinol was associated with an improvement there, but this is the figure that the authors show. I hope it shows up okay. On the y-axis is the negative affect score, and then on the x-axis is the number of weeks. And it's the darkened circles that are the people who got dronabinol first, and then the placebo is the like hollow circles, if you will. And so it looks like the dronabinol group, or the people who got dronabinol first, started off with a much higher negative affect score. And then they had a much more sort of precipitous decline. And so at the time of the switch, it does look like the dronabinol group, had a lower score. Whether or not it was actually a clinically meaningful difference, I'm not sure. But then towards the end of the 12 weeks, the groups don't look that much different. And so I'm just not sure. Oh, there we go. And so these are some of the safety outcomes that the authors reported. And again, since it's small numbers of people, there were only 15 people total, to give you some perspective in terms of the number of events reported here. So again, difficult to detect differences, but I think, we can take a look at the numbers of events because that's what we have. So it looks to be like, certainly for tiredness, there's more people who are tired in the dronabinol group compared to the placebo group, and more people who are somnolent in the dronabinol group compared to placebo. One of the important safety outcomes to come out of the study is that unfortunately, one of the patients had a seizure the day after receiving a dose of dronabinol. There were also 2 other patients who had to stop taking there were 2 other patients who also had to leave the study because they developed serious infection. It's not explicitly said like at what stage of the study, like if they were on dronabinol or placebo, although the authors make it seem as though they might have been in a placebo phase, but I'm not entirely sure. And so to critically appraise this study, whenever I went through the methods, unfortunately, the mechanisms of randomization and allocation concealment were not very clear. However, the authors, were explicit in saying that participants and assessors were blinded. For missing data, they only started with 15 people. So, when they lost 3, that's a large proportion of the people. So the missing data could be a problem. In terms of selective reporting, there was no protocol or registration, although this study was done in 1997, so that wasn't necessarily common practice back then. And as I highlighted, in terms of other bias, there was pharmaceutical company involvement, We know they provided the drug, otherwise we're not sure what else they did for the study. So I would say that's unclear. So the bottom line would be that, there was possible poor or unclear reporting that makes it more difficult to assess for biases in this study. The efficacy outcomes were not really presented in a readily interpretable way either. But it doesn't really look clear to me that there was benefit. And important to note that one patient did have a seizure after receiving their first dose of dronabinol. The thing to note about dronabinol is that it's actually not available in Canada right now, to the best of my knowledge. It looks like in 2012, the manufacturer took it out of the Canadian market, though you can still, it's still available in the US and other countries. And yesterday when I checked on Health Canada website, it doesn't look to be in their drug approval database. But I included some studies with dronabinol because it's there isn't much to talk about. And so I think, we can at least sort of borrow some strength from the trials that are done with this drug. So the next study for us to talk about is to do with cannabis for dyskinesia in Parkinson's disease. And this was published in Neurology in 2004. The authors don't talk about sort of any pharmaceutical industry involvement in their study. So this was an 8-week crossover randomized control trial, included 19 patients with idiopathic Parkinson's disease complicated by levodopa-induced dyskinesias. The participants were living in the United Kingdom, and their ages ranged between 51 and 78. We actually don't know a lot about the baseline characteristics of these patients. They talk a little bit about sort of their Parkinson's disease, but not much about sort of other things that we might be interested in, like all of their other comorbidities and medication use. The intervention in this study was capsules of cannabis sativa, which are 2.5 milligrams of tetrahydrocannabinol, so THC, and 1.25 milligrams of cannabidiol, which is CBD, to a maximum dose of 0.25 milligrams per kilogram of THC per day. The comparator group got a matching placebo. They looked at a lot of different outcomes in this study. The primary outcome was the UPDRS Part 4, items 32 and 34, which had to do with dyskinesia. So 32 has to do with the duration of dyskinesia, and item 34, the pain. They looked at the impact on function, both from a physician perspective and from a patient perspective. They used dyskinesia scales and indicators. They also looked at patient on-off diaries, quality of life indicators, pain scale, a sleep scale, as well as total UPDRS scores, both in the on and off states. And this study was done between May and September 2003. The bottom line is that cannabis was not shown to improve any of their outcomes of interest. Of all those outcomes that I showed you there, it didn't help any of them. And these are the treatment safety outcomes. So they broke it down into physical ailments, psychological ailments, and then total adverse events. And so the N, like the number, is a little bit confusing in that for the individual outcomes, so say it's like dry mouth, altered taste, those numbers are actually participants. So there were like 4 people in the cannabis group who had dry mouth and 1 person in the placebo group who had dry mouth. But when you look at the total at the top, it would be that there were like 18 events total. So it's not number of people. So it looks to be like there were certainly more adverse events in the cannabis than placebo group. So to critically appraise this study, the authors actually did a pretty good job. The randomization procedure was clear, allocation concealment was clear. They tried to do blinding of participants and assessors, although the caveat to that being that when they checked to see if patients could guess which group they were randomized to, 71% of them identified their allocation correctly. There was very little missing data. Only 1 person was excluded from analyses in each group. In terms of selective reporting, again, I couldn't find a registration or a protocol. And for other bias, I think that's right. For other bias, it was actually likely low because there was a statement in the methods where they say that the study drug was provided by the Institute for Clinical Research, IKF, in Berlin, which when I checked to see what that is, it looks to be a nonprofit organization. So in terms of, external validity to our patient population, it's, people with Parkinson's disease. of long duration, but they didn't really talk about a lot of the other characteristics of the study cohort, and this was done in the UK. So the bottom line, apart from being unclear about whether or not there was selective reporting, the study was at low risk of bias. Cannabis didn't seem to improve any of their outcomes of interest, and there appeared to be greater numbers of physical and psychological adverse events associated with cannabis use. So on to the next study. Okay, so in this one, we're looking at cannabinoid effects on ventilation and breathlessness, a pilot study of efficacy and safety. And this time, the study authors said that the drug and placebo were provided by GW Pharmaceuticals. So this was a 2-day crossover randomized control trial, which seems kind of odd. But what I mean by that is that the participants had to sort of come in beforehand, learn how to, interact with the devices, and then they were randomized to come, for 1 day. They got placebo, and then about a week passed, and then they got the other intervention, if it was the drug, or then they were in the placebo group, because of course this was a crossover study, so everyone got both placebo and the treatment. So they had two populations. They had one population of people who had COPD, which they diagnosed as having an FEV1 of less than 60% and greater than 40% of the predicted normal, and an FEV1 to FVC ratio of less than 70%. The age range of people who had COPD was 66 to 68. For the non-COPD group, they had to have an FEV1 of greater than or equal to 80% predicted normal, and an FEV1 to FVC of greater than or equal to 70%. The age range is a little bit young. I know, it's only 51 to 67, but I included this study because it does sort of creep into our older adult population, and it was the only RCT that included nabiximols, which is a drug that is available for use in Canada, though it's not on our ODB formulary. And so nabiximols was the intervention here. It's a sublingual spray that it has 2.7 milligrams of THC and 2.5 milligrams of CBD per spray. And so in the intervention for this study, they could get a maximum number of 4 sprays that were separated by 20 to 30 minutes because they were worried about side effects, of which there were some that I'll show you in a few slides. The placebo group also got a sublingual spray. Their outcomes of interest included breathlessness rated with a verbal rating scale and a visual analog scale. So the verbal rating scale had 7 divisions of breathlessness from mild to severe, and the visual analog scale was consisted of an unmarked 10-centimeter line with not at all breathlessness at one end to extremely breathless at the other. They also included the Spielberger anxiety state and the Thayer activation deactivation scores. Again, they didn't say specifically when the study was done, but it was published in 2011, so we know it was before then. The bottom line for the outcomes is that there was no difference in the anxiety state or activation deactivation scores. There was also no difference in the visual analog score or the VRS score, and tidal CO2, minute ventilation, tidal volume, or respiratory rates. Adverse events that were reported by the study authors included 1 person in the nabiximols group got confusion, 1 person developed a Mobitz type 1 heart block, 1 person had 4 beats of VT, and then in the placebo group, 1 person became drowsy. So to critically appraise this study, the authors were clear about their randomization, although how they concealed allocation was not clear to me. They did say that the participants and assessors were blinded. There was some missing data, however, because again, it's a problem of small numbers, and one person from the COPD patients and 1 person from the non-COPD, both didn't end up finishing the study. And so just based on small numbers, it becomes a problem. For selective reporting, it's unclear because there was no protocol or registration. And for other bias, they said all we know is that the placebo and study drug were given by that pharmaceutical company, but we don't otherwise know their involvement. So to summarize, I would say, really, I'm unsure about the risk of bias associated with this study. Nabiximols did not appear to improve breathlessness, and there were adverse events noted in the nabiximols treated patients, although there was also confusion in the patient who received placebo. So on to the next study then. So this one is for tetrahydrocannabinol, so THC, in behavioral disturbances in dementia. And this is a crossover randomized control trial. I have two different studies on the screen here because the authors actually presented results for the same study population in two different publications. And so that's why I have done that there, in case you're wondering. And it's going to be in very small print, so I'll just tell you what it says. The authors said, the investigation medical product was provided by Echo Pharmaceuticals, which did not provide financial support for the study and had no role in study design, collection, analysis, or interpretation of data, nor writing the report. So the authors try to make it clear that the involvement of the company was very at arm's length. So the study was a 12-week crossover randomized control trial. It included 22 persons living with dementia and clinically relevant neuropsychiatric symptoms, which study authors defined as a neuropsychiatric inventory score of 10 or more, but the participant had to have agitation or aggression. And this was conducted in the Netherlands. And so this study design was actually very confusing. And so I have an extra slide later in case we want to go through it more. But suffice it to say, there was repeated crossover for the participants. And so there was two study periods. There was a period A and a period B. And within period A, patients would be randomized to receive either a placebo or dronabinol at 0.75 milligrams PO twice daily. And then in study period B, they would receive, again, either a placebo or dronabinol 1.5 milligrams PO BID. The study authors looked at a large number of outcomes, as you can see here. So they looked at the total neuropsychiatric inventory score. They looked at the subscale for agitation and aggression. They looked at the Cohen-Mansfield agitation inventory, which, as a reminder, looks at agitation and aggression. They looked at the Zaret burden interview, which is for caregiver burden. They also did the Tinetti performance-oriented mobility assessment, the timed up and go, the visual analog scales score for psychedelic effects, and they reported a number of adverse events, and they looked at sort of lab tests and ECG. This study was conducted between September 2011 and December 2013. And suffice it to say, again, unfortunately, their study interventions didn't appear to have any effect on any of their outcomes of interest. So no difference in any of the neuropsychiatric symptoms, no difference in caregiver burden, although what may be good or not is that it didn't seem to impact the timed up and go or the Tinetti POMA either. In terms of the treatment safety, so this is where the study is reported a little bit interesting between the two publications. So in the one publication, they report that there were no severe adverse events, which is good. I'm glad to hear that. And it appears that there are sort of similar amounts of mild to moderate adverse events. As you can see, they divide it by period. So of course, in the period A, the THC was lower dose, right? It was 0.75 twice daily. Period B, it was 1.5 milligrams twice daily. And then the placebo groups are the placebo groups. And so then and they don't report sort of specific symptoms. They go through sort of like, they had like psychiatric disorders, neurological disorders, so more like kind of diagnosis categories as opposed to the specific symptoms that we might be interested in. And it doesn't look to be that they're that much different either. I put the psychiatric disorders there because I know we're always very curious about that. But then where the reporting is becomes interesting, so for body sway with eyes closed, it looks to be that perhaps at the higher dose of THC compared to placebo that there might be some increased body sway. With the eyes open, it was okay. But then the authors kind of reported conflicting outcome data, if you will, for when they were looking at the systolic blood pressure measurements. Because you can see here, it appears to become lower with the low dose of THC and then perhaps to increase on the higher dose of THC. And that's from the second publication where they report safety data. But if you go to their first publication, which more focused on the efficacy outcomes, they make a statement. They say high dose THC increased the systolic blood pressure by 2.5 millimeters of mercury compared to placebo within 4 hours after the first tablet was taken. but they don't report any uncertainty around that. And so we don't know whether or not it was actually more than the low dose group or than the placebo group. So I don't know why they've reported two different takes on an outcome that is from the same study population, and I don't know why. And then there might be, there is a higher heart rate in the people who got the low dose of THC compared to placebo. So to critically appraise this study, the authors were actually very clear about their randomization procedure, maintaining allocation concealment, blinding of participants and assessors, although there was quite a lot of missing data. And the authors, to their credit, they are clear about where they are missing data, but there's at times quite a bit of it, like up to 33 missing values for one outcome of interest. So that can be a problem. In terms of selective reporting, I was really concerned whenever I found the discrepant results between the two publications. And then for other bias, the authors were very clear about ensuring that the pharmaceutical company was at arm's length. So to summarize this, I would say missing data and selective reporting raise the potential for important bias in this study. Dronabinol did not improve efficacy outcomes in patients experiencing neuropsychiatric symptoms of dementia. And to me, anyway, the safety profile is unclear because of obscure and possibly inconsistent adverse event reporting, which I do think is concerning. So then I think we have time for one more study. And then there's another one after that I don't know we'll get to, but it'll be in the slide deck. And everyone will, in an email, will get all of the different studies that we've talked about today so that you can review them on your own as well. So in this study, again, it was tetrahydrocannabinol, so THC, for neuropsychiatric symptoms in dementia. The study was published in Neurology in 2015. Again, because I'm sure the study funding statement's very small, I'm just going to read it out loud. So it was funded by the European Regional Development Fund and the province of Gelderland. And the medical product was again provided by Echo Pharmaceuticals, which did not provide financial support for the study and had no role in study design, collection, analysis, or interpretation of data or writing the report. And so the study design, so this was a 3-week randomized control trial. It was parallel groups, so no crossover this time. It included 50 persons living with dementia and clinically relevant neuropsychiatric symptoms, which they defined as having a neuropsychiatric inventory score of 10 or more with symptoms of agitation, aggression, or aberrant motor behavior for at least a month. And this was conducted in the Netherlands. And they recruited people from the community, clinics, and nursing homes. So 24 persons were in the intervention group, and they received dronabinol, 1.5 milligrams POTID this time. And in the comparative group, there were 26 persons who received placebo. They looked at several outcomes that are listed here. So the neuropsychiatric inventory total score, the Cohen-Mansfield agitation inventory, which again reports both agitation and aggression. They report a quality of life measure, the Barthel index, which of course looks at activities of daily living, as well as a caregiver clinical global impression of change and adverse events. And this study was conducted between November 2012 and June 2014. And again, the bottom line would be that it didn't appear to improve any of their efficacy outcomes of interest. And one of the things about this study is that they changed their inclusion criteria sort of after enrollment had already began. And so originally they had wanted to have people with both neuropsychiatric symptoms and with pain, but then they realized that they just weren't able to recruit enough patients. And so then they started just enrolling people who had neuropsychiatric symptoms. But the authors did still look at a pain outcome, even though they weren't making that sort of an exclusive making that an inclusion criteria. And I couldn't access, it's a weird thing. So with U of T, I was able to access the paper, but none of the online supplemental appendices were available for some reason. And so what I do know is that the authors say there was no impact on pain-related behavior or pain intensity, but I don't actually have the numbers to support that. Just that's what the authors are saying. In terms of safety profile, this is the authors report. There's a very big table, and so I couldn't put it all in one slide. So I sort of picked out some of the things that I knew we would be interested in. And the one thing to note is that they used this international sort of reporting system for how to categorize outcomes. And so one of their outcomes was cognitive disorder. But I thought, well, what is that? Because, there's 3 people in the THC group and 1 person in placebo who had a cognitive disorder. And that actually encompasses a number of different things. It includes mild neurocognitive disorder, cognitive disturbance, cognitive deterioration, cognitive disorders, cognitive impairment, and cognitive function abnormal. So a lot of different things. They did separate out delirium. It appears that only 1 person in the delirium or in the THC group got delirium and no one in the placebo group. But anyway, so and again, it's small numbers, so it's hard to detect a difference between groups. But you can certainly look at the absolute numbers of people who are having different events.
Generally, the adverse events, are these all adverse events or serious?
I think it was all events. And so then for critical appraisal, this study was actually really well done, because I don't often give something sort of like low risk of bias across the board, and this study definitely earned that, or it appeared to. So, the randomization was good, the allocation concealment was good, patients were well blinded, very little missing data. They had registered their study, and so you're able to see what they were working on the clinical trials website, and they were clear about the involvement of pharmaceutical company. And so overall, I would say the study was at low risk of bias. Dronabinol 1.5 milligrams PO/TID did not improve efficacy outcomes in patients experiencing neuropsychiatric symptoms of dementia. There was that sort of unclear signal of harm related to cognitive disorders. So as I said, it's small numbers. And so, you can't say for sure based on that, THC is associated with increased cognitive disorders. But there did appear to be more like a greater sort of absolute number, if you will, is sort of all we can say about it. Oops. And so what I'll do, because I don't want to, so this is actually a good study, and you'll have the paper if you want to review it. And the one thing that I will point out is that it again was involving dronabinol and placebo. And this is the study and it's an 8-week crossover study. And what I will show you from this study is that the authors were able to show that there was increased amount of adverse events as you increase the doses of dronabinol. So by the time you get up to 6.5 milligrams of dronabinol, you get 22 people experiencing an adverse event compared to only 1 person in the placebo group. But I don't have time to do the study justice, and so I'll leave the slides there so that you'll be able to read it. So then in summary, is cannabis efficacious? Is it harmful? Can we trust the results of the studies we've reviewed today? And what studies can we expect to hear about in the future would be sort of the thoughts I would leave you with. So based on the studies we've reviewed today, which does really represent the state of the literature for our older adults right now, I couldn't say that cannabis really works. As you saw sort of across the board, there weren't really benefits demonstrated in any of these studies. Is it harmful? Maybe. Again, small numbers of people make it difficult to actually detect differences between groups, but we can certainly see, based on absolute numbers, that there was perhaps some signals of harm, and certainly in that last study that I didn't get into, but you will have. You can see that there actually was a demonstrable increase in adverse events associated with dronabinol use. And, can we trust the results? Well, some studies were better than others, right? And you could see that. And so it's hard to say right now. The literature is quite heterogeneous. And then what can we expect in the future? So I went to Clinicaltrials.gov just to see what's coming down the pipe. And so whenever I looked at, studies that are not yet recruiting, are recruiting, or they're active but not recruiting, and inclusion criteria includes older adults, 65 plus, there were 108 studies that appeared. So hopefully, at least some of those studies will be either exclusively in older adults, or they'll include a subgroup from which we can derive more information to try and help inform our conversations with patients and caregivers. And so that's everything. Thank you.